Well, it's been a rough few months for acute care in Alberta. Alberta's emergency rooms continue to run at or over capacity. Doctors are calling for a state of emergency to deal with the crisis. The Alberta government, though, says they have things under control. We'll take a look at how things got so bad and what can be done to address this crisis next on the Line Alberta podcast. Hey folks, welcome to the Line Alberta podcast. My name is Rob Breakenridge. Great to have you along with us this week as we delve into what's been a big story in Alberta in recent weeks, the situation in acute care, the delays, the problems in emergency rooms right across the province. For weeks now, Alberta doctors have been calling on the Alberta government to declare a state of emergency, and that's how bad things have gotten. Now, there were weeks of silence from the Alberta government as these problems and these criticisms were mounting, but we did finally get an update last week from the province. Now, one of the big announcements, and this concerns a really big story that attracted national attention, it really highlights some of these issues, was the tragic death of a 44-year-old man at the Grey Nuns Hospital in the emergency room back on December 22nd. One of the announcements from the Alberta government is that there was going to be a fatality inquiry into this death. This is a 44-year-old man. According to his family, he went to the ER experiencing chest pains, but wasn't seen for 8 hours before he finally passed away. So was this death preventable? Was this death attributable to these delays and problems that emergency rooms are experiencing? And are there other stories like that? This week, we also learned of a letter that's been sent to the Alberta government, compiled by emergency room doctors in Alberta, that details other preventable deaths and near misses, urging the Alberta government to take some steps. So as mentioned, the Alberta government did address the problems last week, announcing this fatality inquiry. There was also a press conference to talk about what's being done to acknowledge some of the problems in the system. It's now Hospital Minister Matt Jones who was responsible for speaking to all of this. There's been a lot of restructuring when it comes to healthcare in Alberta and the responsibilities for healthcare in Alberta. So we don't just have the one health minister anymore. We've got some different portfolios and responsibilities. So as mentioned, it's Hospital Minister Matt Jones taking the lead on this issue and was asked about that last week. Who takes responsibility here? Is there accountability here? This is what the minister said.
Minister, will you admit that your government failed to plan and build enough bed space, particularly in Edmonton, to meet Albertans' needs? Because everybody on that stage agrees that that's an issue, that may be the major issue here, and ultimately it is your government's responsibility to build and staff those beds, correct?
Thank you for the question. I will fully acknowledge that we should have more acute care capacity in the Edmonton area than we do today, which is why I initiated a long-term capital plan, a 50-year capital plan, so that we are no longer behind or reacting to pressures, but we have a plan in place to build the appropriate acute care capacity wherever it's going to be needed as our population grows and shifts and ages. We also, as you saw in the acute care action plan, very quickly after being appointed to this position, I launched the expansion of 1,000 acute care beds in the Calgary and Edmonton region for exactly this reason. I believe we need more acute care beds in Edmonton and Calgary, but there's also other things we need. We need to continue recruiting healthcare professionals. We've recruited 600 doctors year over year, 1,000 RNs, LPNs, and healthcare aides. So ultimately, yes, I am accountable. And yes, I believe that there could have been greater capacity built in the years and decades, frankly, prior to today. But, the government deals with competing priorities across the board. We have education, we have social services, we have other aspects of healthcare beyond acute care that also require allocations, and these builds take significant time. So, yes, accountable. Yes, wish we have more. The plans are in place. The construction has already started. The money is allocated, and we're going to begin addressing the gap in capacity that I think does exist in Calgary and Edmonton.
So it was interesting and significant, perhaps, I think, to have an Alberta government minister acknowledging that there are these problems in the system, acknowledging that the province doesn't have the capacity it needs, and perhaps those decisions should have been made in the past, and also saying that he takes responsibility for this. And really, it is the Alberta government's responsibility when it comes to healthcare, especially the emergency side of it. Now, one more clip here from the minister I wanted to play for you, and this concerns the question of how bad things are and what's needed in response. As mentioned, there have been a growing number of calls on the Alberta government to declare a state of emergency to deal with this situation. The minister was asked whether he thought that was necessary, and if not a state of emergency, what other steps could be taken to address things.
We're hearing from doctors that the government was warned that this flu season was going to be particularly bad. It seems like what's happening right now is very reactionary. I know there has been efforts made previously, but knowing that this flu season was going to be bad, why wasn't some of this efforts with moving patients out already done ahead of time to ensure that hospitals weren't experiencing this?
So planning for respiratory virus season occurs months in advance of respiratory virus season, and I can assure you that patients were being decanted from hospital who no longer required acute care. For example, since Assisted Living Alberta started a dedicated effort to transitioning ALC patients, they've reduced ALC patients by about 20% across the system. At certain hospitals, that's over 35%. So this work very much did start before and in advance of respiratory virus season, as did our decision to permanently add over 200 beds permanently in anticipation of a busy respiratory virus season. And then we stood up an additional 130 or so surge. So that's not true. There was months of active planning and coordination in advance of respiratory virus season, which is why you have not seen mass cancellation of surgeries, for example, which is one of our levers to provide additional capacity in the system.
The call also for the state of emergency, we know from the government that at this point, like, that's not wanting to be said. It's also, are you though willing to admit that hospitals are in a crisis right now? Like, is that fair to say?
Hospitals are under extreme pressure, including the emergency departments, and we need to build more capacity, and we need to continue to add physicians and healthcare workers, absolutely no question. A state of emergency, I think there was a misunderstanding as to what powers that grants the province. I don't need to seize anyone's land or go on it without warrant or stand on the street distributing medical supplies. I have the tools, as does Acute Care Alberta and my ministry and the other agencies and ministries. We do have the tools to appropriately respond to respiratory virus and hospital pressures. And in the event that we would need to escalate to obtain additional powers to manage a situation, we would, as governments have in the past.
So the government doesn't believe that a state of emergency is a necessary response to the situation, but they do say that they are responding. They are providing resources. They say they're going to establish a new dashboard so Albertans have a clear indication of what's going on. I think one of the real concerns right now is just how worried Albertans would be about going to an emergency room. But if needed care is being neglected, what were the consequences of that? Something else the Alberta government's going to try out, and it's actually something we've done in the past, is the idea of having a triage liaison physician on duty in emergency rooms. So this is going to be piloted in 5 urban ER settings, where essentially then you have a doctor who's a part of that initial triage to just get a better understanding, I guess, of what patients are presenting with, and hopefully be able to have some kind of early intervention that could head off some of these potential worst-case scenarios. So some critics have dismissed this as a Band-Aid, but clearly something needs to be done. I don't know if the status quo is sustainable at this point. I mean, yes, a lot of this pressure stems from a particularly bad season with respiratory illness, influenza in particular, but there's some other structural issues going on here. So yes, that influenza wave, some of that illness, that will peak and some of that will pass. But a lot of these pressures will likely remain. There's also the issue of what's happening elsewhere in the healthcare system. Are people going to ERs because they don't have family doctors to go to? Are people being stuck in ER because we don't have other places to send these patients, like with independent living, for example? So that becomes another challenge, is what's happening elsewhere in the system and how does that place additional pressure on acute care? So I want to get a better understanding what's happening within the system, how we got to this point, and what steps need to be taken to try to address this problem moving forward, both in the short term and in the longer term. I had an opportunity to have a conversation with Dr. Warren Thirsk. He's an ER physician, in fact, was coming off an ER shift the night before we spoke and was heading off to one a little bit later on after our interview. He's also with the Alberta Medical Association. He's the AMA's president of the emergency section. So he's been at the forefront of this conversation on the policy side and, as mentioned, on the front lines, working in emergency rooms and dealing with all of these issues. So some particularly interesting insight, I think, into this whole situation. So let's now go to that conversation with Dr. Warren Thirsk. Well, joining us now for more on the situation in Alberta's emergency rooms and what steps are needed to address this crisis in acute care. Very pleased to welcome to the Line Alberta podcast, Dr. Warren Thirsk. He is president of the Alberta Medical Association's emergency section. Dr. Thirsk, so good to have you with us here.
Thanks for having me.
I know you're coming off an ER shift last night as we record this and getting set for another today. Just first of all, I mean, what you're seeing yourself, you know, where we're hearing from the Alberta government that maybe some of this crisis that they've now conceded is been happening is starting to pass, or some of it is subsiding. Or are you seeing any signs of that, first of all?
We're seeing a small decrease in the number of patients presenting and the number of ambulances, but we're still underwater. So the wave has crashed over top, but we're still drowning.
Yeah, I mean, we saw numbers last week indicating that we still have a system that's operating at over 100% capacity. So clearly that in and of itself speaks to this challenge that we're facing right now. So if we take a step back, and I know, you know, we spoke some months ago, you were urging the Premier to come and see what was happening in emergency rooms firsthand. So this didn't just start last month or a few months ago. This has been building for some time.
Yeah, it's been building for over 20, 25 years. So there has been a longstanding failed narrative, I think is the best way to say it, a failed story that the healthcare system was full of excess waste and there would be no future growth, and all future growth would come inside the cuts and the excess waste. And so we continually have trimmed for 20 plus years healthcare staff, healthcare infrastructure, and have not accounted for the other changes that Alberta has seen: population growth, population aging. And so it was a flawed narrative, and we are seeing the outcome of sticking so doggedly to this story and failing to heed the warnings that myself and other emergency doctors were giving 20 years ago, as we started to see, being the focal point when the system starts to fail, the failure is coming. And this is just amplified, and it continues to amplify.
Right. So there's deeper structural issues. There's also the pressures that we might happen to be dealing with at any given moment. So certainly over the last couple of months, Alberta and other parts of Canada have been experiencing a really bad flu season, for example. That puts additional pressure on the system. But to suggest that this was caused by flu or a bad respiratory illness season, that wouldn't be accurate then, would it?
No, that's another failed narrative where we would like to believe that it's a transient flu event or something that is, you know, just going to pass by and that will return to normal. And so that's why I use a water level. Our heads are underwater. If the hospitals that are at 100% capacity or 110% capacity, they're drowning. And so we don't have a place where we're below capacity and then the waves come and, you know, we have temporary bits of overcapacity. We are over capacity and the waves are crashing over top, but they're not the problem, right? The problem is that we are way too deep. We're in over our heads, essentially. And this is from both a structural, lacking hospitals in the city of Edmonton, for example, failing to build hospitals, canceling hospitals in this city, and it's a failure of staffing. So we have cut doctor positions, were cut in the 90s and have never recovered to baseline levels of what was the previous cuts, despite doubling the population. And so we have no family doctors because we haven't trained them. We have no nurses because we're not training them. And that would be one of the solutions, probably, would be to, you know, start now training people to look after people.
Well, we just, of course, went through a pandemic in recent years, and we saw what can happen when the healthcare system becomes under such immense strain. And I mean, one of the problems that was identified was that lack of capacity. I remember, Danielle Smith, who is now the premier, talked about, well, we should have more beds. There should be more capacity. I guess it's one thing to talk about it outside of politics. It's another to do that once you're in a leadership position. But I mean, did we learn any of those lessons from the pandemic and the impact that had on acute care in this province?
I'm going to say I haven't seen evidence that we've learned a lot from those lessons, unfortunately. We're still not seeing the rolling up of the sleeves and the hard work that infrastructure requires. So training a person to look after someone else takes time. So if we're not training that person today in school, right, the nurse will take 4 years to graduate from an RN degree program. The doctor is going to take 6 or 7 years to get through medical school, residency training, and be a functional family doctor for us in the community. The specialist in the hospital is going to take 7 to 10 years. We need to do today what we hope to have for us as resources in 5 to 10 years. And it's the same thing with building a hospital. That's a multi-year event. Yeah. And just like I said, the experience of the city of Edmonton, where we've had 3 planned hospitals and lots of resources into planning, and then the plans get cut or changed, and we've ended up with 2 day hospital urgent care centers that don't have hospital capacity, operating rooms, or the things that most of us associate with a hospital, have to transfer all their sick patients out. So we have 2 sites like that, and we have a hole in the ground that was started and then canceled. So as we announce new plans or want to build a new tower somewhere, it's like a little too late to help. And will take 5 years. So the small amounts announced take time.
Well, in terms of then what we can even do in the shorter term or the medium term, I know last week, and one of the ideas the Alberta government has talked about, and we've tried this before, the idea of having, I guess, what they call triage liaison physicians. So sort of a doctor who's kind of at the front of the line trying to get ahead of the situation as waits build in ER waiting rooms. What do you make of this role or this position? What impact could that have?
Well, I've previously worked it, so it was in place in our hospital until it was cut by a Conservative government in 2013. So this is an old idea coming back. And at this stage, it's like a Band-Aid, and it always was intended as a Band-Aid on a gaping wound. So if the hospital and the system is functioning well, your unplanned medical event, when you slip on the ice and break your wrist or you have a heart attack, we should have the capacity to see you in a reasonable amount of time. Those, reasonable times were decided, 30 years ago, what would be reasonable, and published. And we've now accepted a lot worse times and waits, such that people say, I only waited 8 hours. It was a good day. And that's not a good day. That's double the longest acceptable wait time that would be considered a good healthcare outcome. Yeah. So, having done the TLP, I can tell you that it has some efficiencies, absolutely, and it has some benefits. If you're seen quickly, not fully, but quickly, by a doctor at triage who says, I think you need these 5 blood tests and this x-ray, and they actually get ordered by the doctor at triage, it has a chance of speeding up your stay in the emergency department, because the x-ray and the tests can happen while you're in the waiting room, while you're waiting for a care space where you could actually be undressed, where a proper exam could be done. The guess was done at triage, and we'll try to get most of the work started and happening then concurrently. So then your 2 waits are concurrent. You're waiting for a care space, and so you're waiting for lab tests to come back. Because right now those are linear. You're seen in a care space, the doctor does a real job, a proper job of assessing what you need, orders it, and then you wait for it to come back. Mm-hmm. So it does speed up, some parts of the process for sure. It has chances to make mistakes and have waste, because, and this is a common doctor experience, what the patient will, present with may not be the problem. So you could tell me that you have chest pain, and I could go looking for heart attack, and that's easy to order those tests at triage. But let's say your chest pain turns out to be a cancer. Well, because I didn't like fully undress you because we're in public and it's the lineup at the triage. Because I didn't do a proper exam, I failed to notice that you've got, no air movement on the left side. And guess what? You have lung cancer. And we have to change the tests, change directions, do a 180, right? You could have like lots of different things happening. Medicine is far more complicated than just a equals B linear process. It requires some work and skill, and triage doctors don't have the ability to do that in the triage line. Right. So.
Well, and we think of we had this tragedy recently, of course, that has underscored, I think, the crisis in our system, where a 48-year-old, as we understand it, was experiencing chest pains, waiting 8 hours, ended up, succumbing to his ailment. So, I mean, there will be a fatality inquiry into what happened there, but you think then maybe if there are those earlier interventions, could we address some of those potential tragedies? Because I don't think that was an isolated incident either.
It's not an isolated incident. So this is the tip of the iceberg. That is a patient and a family who, told the world through the media about their denial of care, their bad experience, right? And it's under judicial review, and I don't think I should talk about a specific case in that way. Right. But I can point to other examples. So in the Globe and Mail, there was an article about a 90-hour wait for hospital admission at the University of Alberta Hospital here in Edmonton. And during that article where they described, their family situation, and other families spoke up. What struck me most as the healthcare provider who would be looking after that patient and all the patients until they get admitted into the hospital, is that they talk about the 12 stretchers in little cubicles. Right. There are no toilet, no sink, no bathroom, no food, no facilities, skeleton staff, just waiting to be moved into the hospital, admitted to hospital, needing hospital. But there was 11 other stretchers. So the one that came forward to the media is the tip of the iceberg. And there's 11 more stories that would be equally suffering filled, equally painful, equally difficult to watch, would have other families struggling. And those stories aren't told. As healthcare providers, we can't tell those stories. So I know theoretically, and if I was the doctor at that day, I would know exactly who's in those beds and what their problems were and the suffering, but I can't express the story. I have given, go ahead.
No, I was going to say, yeah, and that, I know that letter was compiled by other ER doctors that's been sent to the Alberta government, but it details a number of instances where we have what appear to be preventable deaths or at least near misses. So it's unfortunately, it seems almost common right now, just given everything we're dealing with.
Every day.
Yeah.
Every day. Tip of the iceberg. So the document that I believe has somehow hit the media and been leaked is just the tip of the iceberg, where frustrated doctors feel that no one's listening and have nowhere to turn. And obviously it is being collected in a central place where it was hoped and is hoped that the people who make decisions, government, because right now everything seems to come from the minister down, are going to see that this is like not a one-off. This isn't flu. This is a systemic problem that leads to untold massive amounts of suffering, near misses, and problems. And as people looking for solutions, the first part is to recognize we really have a problem.
There's the other side of it too, and we can sort of detail the experience of those who are waiting or are not seen, and what can potentially happen. I know there's the other problem of people leaving, people presenting to ER with whatever they might be dealing with, and facing a lengthy wait or just facing uncomfortable conditions, and they decide to leave, and so they're not seen, they're not treated. Whatever they're dealing with can exacerbate, can have a tragic outcome, or present later on in the system as something more serious. What about that side of it?
Well, we just know that it's bad, right? We know that because you were sick enough to show up and have a medical emergency, and then you were so frustrated with the denial of care that the wait time represents, that you left without care either being started or completed. We don't know what happens to these folks, right? And so you might show up at a different hospital, the next day with something really serious as you continue to get worse. But that's not captured or recorded. We simply know that you registered and left. Right? The events aren't connected. privacy like protections in law prevent healthcare workers from easily matching up these cases. It's just like it prevents me from easily sharing, the stories of what we see on the front lines as the gaps, because to do so risks violating someone's privacy who says, hey, on media, I noticed you talked about my case. So I could give you hundreds and thousands of examples, but then if the family identifies themselves and feel I've violated confidentiality, then they would rightly be upset. Patients have to start finding their own voice. The person who leaves needs to say, hey, I waited 12 hours, I got fed up and I left, and this happened to me. That would be the better way to have this conversation.
And what about how this ties into other aspects of the healthcare system? One issue that's been identified over the years is lack of a family physician for a lot of Albertans, and oftentimes people have nowhere else to go. I think one of the challenges that's been identified more recently is in, for example, assisted living, where you've got a lot of people who are stuck in emergency room beds because there's nowhere else for them to go. So how is this compounding the problem right now?
Well, it's all reflected in what we see in the emergency department, because we're everyone else's backup plan. If someone is too unsafe to live on their own and needs a nursing home or alternate level of care bed, and the family can't handle them at home, they're wandering into winter and it's dangerous, they're going to end up right in the hospital, in the emergency department. If they fall and can't get up and can't walk and they need a nursing home because they can't ambulate, they're coming to us. So we're just the focal point for everything. Every gap, though, that we see across the entire healthcare system has had that same failed narrative I mentioned before, of the idea that we're not going to build for anything because we think there's fat. So we're going to keep, trimming, and we're asking any growth to occur inside the fat. Well, these two hands met 20 years ago, and we're now doing this. Right. There is no capacity, and we actually continue to trim. So there have been ongoing cuts to different areas, chasing financial, frugalness. Fiscal responsibility is usually how it's framed, but then it becomes a denial of care to Albertans who expect care.
You talk about the need, obviously, for more physicians as we build up a system that has the capacity to deal with all of this. But even the physicians we have now, those who are going into acute care, and those like yourself who are working in acute care, and the kind of pressure and even burnout maybe we're seeing, what kind of toll is this all taking on doctors, and how does that impact our ability to recruit and to build up?
Well, if there was a doctor somewhere who wanted to come to Alberta and come to an area, whether a rural emergency town or hospital or into the big city, when they see the overworked, burned out doctors that are there, they think that there might be a better place to work for them as people, because, they are seeing the temperature of the water. They see everyone drowning. And it's not easy to recruit in those situations, but we're just frankly not training enough people. So with the new TLP announcement, at 5 hospitals, if they run 2 shifts a day, then they need 10 doctors a day. So the minimum number of emergency doctors just to fill that new role that was announced would be 25. In this province, we're graduating, I think, approximately 20 new emergency doctors in June 2026. So our entire graduating class cannot fill the need of the new announcement. And then that doesn't account for anyone burning out, retiring, getting old. And guess what? Emergency doctors get sick. I've lost a colleague to cancer recently. We're people too. We need healthcare, and we cannot sustain these unsustainable levels. We have no replacements. So the pipeline is empty. The minimum would be to start doubling nursing schools today, so that 4 years from now, I have nurses on the front lines, doubling medical school today, so that 6 years from now, you and I can find a family doctor with the latest ones coming out. And it's still going to take another probably 20 years to dig out of this hole that we've created. We need nursing homes, probably need to build some. Yeah. We need cancer care. We need surgical capacity. So all of the things that we're lacking are denials of care and this failed narrative.
So in the meantime, amid hope that maybe this illness wave is passing, or maybe that some of these Band-Aid solutions can at least make a little bit of an impact, are you at all optimistic that in the weeks and months ahead we'll see even some small signs or gradual signs of improvement?
Well, the wave will pass overhead, but we're still underwater, and we're just, as going to be underwater the next time when the next wave comes. So we're still drowning. We have been drowning for a long time. And I've used the apple tree analogy before, like the desire to wander around the apple tree looking for low-lying fruit while we have lots of people around us starving who need apples isn't working anymore. And so, even this new idea of a TLP is an apple we threw away 10 years ago. In 2013, we threw this apple away, and we're offering now an old apple to a starving population. And so it's going to help a little bit, absolutely, but it's incomplete. And what we need to do is build the ladders and train the people to climb the apple tree and get to the higher apples. Like, it's time to start doing the work that is required to, resource people the way they want to be for healthcare. It's a resource, not a commodity. This isn't a market, and the market has failed to provide the resource.
All right. Well, much more, albertadoctors.org. Dr. Warren Thirsk, thank you so much for your insight on this. Really appreciate making some time for us here today.
Thank you for having me.
Our thanks once again to Dr. Warren Thirsk. Again, he is president of the section of emergency for the Alberta Medical Association. So they're urging the Alberta government to take some drastic action here, both short-term and longer-term, to address acute care in this province. So I don't think this issue is going away anytime soon. I mean, as mentioned, we've got this fatality inquiry into this death at the Greyhounds Hospital in December that I think maybe will shed a lot of light on this problem, or what's needed to address this issue. And it will be interesting to hear what the Premier has to say. Danielle Smith, of course, had been away over the winter break. As of this recording, she hasn't commented publicly on any of this. So I think it will be interesting to hear what she has to say about these issues and what she thinks needs to be done here. Again, I think going back to the pandemic, when Danielle Smith was out of government, she saw this as something relatively easy to address. And she has criticized Alberta Health Services, which basically no longer exists, but criticized them for just not ramping up acute care capacity in the midst of the pandemic, suggesting or implying that that's relatively easy to do. But I think, as we've seen, it's not so easy. Now, again, as mentioned, this isn't an Alberta-specific problem, but I don't think that's an excuse either for provincial governments to just throw up their hands and say there's nothing we can do. It's a problem elsewhere. This is provincial responsibility, and surely they want to keep it that way. The interesting angle in Alberta, though, too, is the restructuring that's happening within healthcare, and the Alberta government's belief that in certain circumstances, market forces or private competition can play a role, can make the system more efficient. But does any of that apply to emergency care, to acute care? I think you heard Dr. Thirsk allude to that this isn't a marketplace, aren't market forces at play. It's just too much demand in a system that's not able to handle it. So what kind of reforms could exist in an emergency room, in an ER, an acute care context? Or is it possible, even though, that if you can make necessary changes and improvements elsewhere in the system, that can at least alleviate some of the pressure, both in terms of people having access to family doctors on the one end, or on the other side, making sure patients aren't stuck in emergency rooms because they have somewhere to go to continuing care, assisted living, etc. I know the Alberta government has taken some flack for its approach to preventive medicine when it comes to, for example, vaccines, immunizations. Can that help alleviate some of the demand on the system when you've got a real bad year for respiratory illness? And certainly what's been happening with influenza in particular, as well as COVID and RSV and other diseases, that's added to a lot of the pressure on the system. So I think all of that yet to be sorted out. And I think the Alberta government needs to lay out what it intends to do here. So as mentioned, we'll see what happens with that fatality inquiry and what more the Alberta government, or the Premier in particular, has to say about all of this. Don't forget, you can find us, follow us, like, subscribe, all of that, alberta.readtheline.ca. My name is Rob Breakenridge. Thank you so much for joining us on this episode of the Line Alberta podcast. We will talk to you next week. Take care.